excited today to have Daniel joining us all the way from London. So it is 11 p.m. for him, so extra thanks for taking the time and presenting.
No problem.
Daniel will be presenting their latest Nature Communications paper that talks about how causality is important for medical imaging. And we're very excited to hear that. And just a little bit about Daniel's background. Daniel is completing his PhD thesis on machine learning for medical imaging at Imperial College London, and will soon be joining the healthcare intelligence team at Microsoft Research Cambridge. Daniel's been working towards integrating clinical and demographic information into generative image models to derive causal insights at population and individual levels. Generally, his research interests include causality and probabilistic modeling with a focus on heterogeneous data. And we're very excited to hear about causality and how we should think about it and how we should try to integrate it into our deep learning models. And just in terms of the structure, we'll be having this presentation for the first 30 minutes or so, which will be recorded. And after the presentation is concluded, then we'll stop the recording, and hopefully we can use that time for some Q&A with Daniel. So please take it away, and thank you again for joining.
Thanks for the introduction, Akshay, and thanks everyone for joining today. I'm really excited to talk about our recent work on causality. So I'll start with a little bit of background and motivation. Okay, so just to start with a bit of context. There's been lately some growing awareness among healthcare regulators of the need for responsible reporting in machine learning for health. And there's been increasing efforts to outline best practices for the safe development and monitoring of AI-enabled technologies. So here, just a few clippings from the last couple of years. And actually, even guidelines for traditional clinical trials are now being adapted for to cover AI-based interventions. So actually, many of you may know that just yesterday, there have been brand new Spirit AI and Consort AI guidelines were released. And what was really interesting to me to see was that they now include these specific considerations about data-driven technology. So things that you wouldn't necessarily need to think about when you're trialing a drug or a new intervention in the kind of surgical sense, for example, or a new device. So things about inclusion, exclusion criteria when you're adding some data to your training data set. Things about selection criteria, acquisition of the data, pre-processing, and also how noisy or missing data were dealt with, if they were imputed in some way. So all of these are now in these new guidelines, so to kind of set this framework for more rigorous testing of AI systems in clinical context. And in parallel, there's always also been a surge in discussion in the medical community itself about opportunities, but also crucially the risks of deploying these tools in clinical practice. And from what I gathered, most of the apprehension is about the external validity of these models. That means how well do they generalize outside the controlled development environment in the lab? And in particular, there are concerns about the robustness of these models. So is the training data that we have representative of the target population that the model is going to see once it's deployed in a hospital? Do we have enough machine learning ready data available that is high quality, annotated, with, quality controlled, and so on? Is the data reliable, or is it full of bugs and errors and mistakes that can come from all sorts of sources? And also, finally, do we have enough information about the task we're trying to solve, or is there maybe some confounding process that we're not accounting for between our inputs and outputs of the prediction we're trying to make? And what's really important here is that all of these different considerations can be better understood using causal reasoning, and that's thinking about the whole story of the data set, all of the different elements that interact with each other to produce these potential shortcomings in the experimental setup. So now, I know that maybe not everyone is necessarily familiar with causality. So here's just like a very, very brief causality 101. We say that a cause causes an effect if controlling for everything else, forcing a change in the cause can produce a change in the effect. And we call this relationship between the cause and the effect the mechanism. And a fundamental principle on which most of the causality theory is based is this assumption of independence of cause and mechanism. And that is that the distribution of the cause does not inform or influence the distribution of an effect given a cause. Basically, what this says is that this lets us think of the whole system as a network of autonomous mechanisms. So that means that we are able to intervene on specific sites in this bigger system without changing everything else. And this is really important for for all of this reasoning to work. But actually, it's not much of a stretch. So it's not a huge assumption. That's just how things work. Now, how does this relate to medical imaging? So let's start with when we're doing medical image analysis with using machine learning, what are we trying to do? So usually we have some task that we have some annotation Y. So that can be some diagnosis label, some image segmentation mask, maybe a bounding box, or something that is that we're trying to predict. That will be our the output of the model and the images. So we're trying to estimate this distribution of Y given X by fitting some statistical model, so maybe some neural network or some other classical machine learning method. And it's important to know what causes what, right? So because this can have an impact on whether certain techniques work, like semi-supervised learning, as we'll discuss later, whether we should prefer generative or discriminative methods. And basically, we call causal prediction when X causes Y. Remember that we're always trying to predict Y from X, but when X causes Y, we're predicting the effect from the cause, and we call this causal prediction. But now when Y causes X, we're predicting the cause from the effect, and we call this anti-causal. And crucially, we can't determine this unless we have enough meta information about the data set. So in machine learning, it's often the case that practitioners will just treat this, oh, I downloaded some data from Kaggle, and I basically just had inputs and outputs and just throw a neural network at it. But this kind of relationship, whether image causes the target or vice versa, we really can only understand if we know how this data was generated. Now, to illustrate this discussion, I'm going to go over two clinical examples and hopefully illustrate this a bit better. So the first one is on skin lesion classification. So we have some collection of dermoscopic images, which are basically close-up photographs of moles. And we have some diagnosis labels from biopsy. So here we're trying to predict if it's some kind of maybe malignant melanoma or something of the sort. Now here, these diagnosis labels from histopathology are basically our gold standard for the presence of cancer. So clearly here, presence of cancer causes the appearance of the image. So maybe if I can get the pointer here. Here on this left-hand part of the diagram, we see disease causes the image, and we're trying to predict in the other direction. So this is anti-causal prediction. And we'll come back to the rest of this diagram later. And the second example here is brain tumor segmentation. So we assume that we have some cohort of glioma patients, and we had a team of radiologists sit down for several hours, painstakingly contouring maybe the different regions of the tumors in these structural MRI scans. And So X here are the images, Y are these manually drawn masks, basically. And obviously, here the segmentation maps are drawn over the images. And if we manipulated the image before the mask was drawn, this could change the segmentation map, right? So here clearly the image causes the segmentation. And as you can see here in the diagram, the arrows are pointing in the same direction. So we're predicting the effect from the cause, and this is causal prediction. Now, and we'll come back again to the other part of the diagram a bit later on. Now let's talk about the one of the big challenges in machine learning for medical imaging, which is scarcity, data scarcity that I alluded to at the start. So basically, when we don't have enough annotated data, what we can do is try to look elsewhere for other sources of data. And it's often the case, especially in medical imaging, where it's so expensive to collect these annotations. We often have a bunch of unlabeled data lying around. And semisupervision is a technique that promises to improve the prediction of some predictive model that we train on the data by using more unlabeled data. Now, of course, for this to make sense, the unlabeled data needs to be useful for this prediction, right? So P of X, which is the distribution of the unlabeled data, needs to tell us something about the this discrimination P of Y given X. And this is normally phrased in the literature in terms of a number of different assumptions that, for example, data of different data of each class will tend to cluster together, or maybe the decision boundary lies somewhere where there are rarer images, or label smoothness, that within a cluster, the labels will tend to be similar. Now, if we recall that principle of independence of cause and mechanism that I mentioned at the start, semisupervision shouldn't work when we have a causal prediction task. So if image causes the annotation, then by that principle, P of X would not tell us anything about P of Y given X. And as we saw in the brain MRI segmentation example, segmentation is causal, right? So we're drawing something on top of the image. Now, we speculate that because this is a causal task and because of these considerations, semantic segmentation may not benefit fundamentally from semisupervision. Now, this is speculative. There's still, we recommend in the paper, some more empirical validation of this. And there are some caveats. We know that in some cases, using more unlabeled data can help improve the predictions from a model, but these are more algorithmic benefits, improving convergence rates, some regularization effects, and things like that. So this is just something that came up from our analysis, and we thought it was interesting to share and kind of raise awareness and hopefully prompt other groups to kind of look into it and question whether these assumptions make sense and whether we need to do something about it. And another common technique to use when we don't have enough annotated data is just to generate more. So here data augmentation is the practice of taking a bunch of annotated data and generating new pairs, synthetic data, based on those. So taking inputs and outputs, and you can do transformations that either don't change the output and change only the image. So for example, for certain kinds of tasks like classification, for example, diagnosis, screening, or something like that, we have a label and the image. You maybe apply some contrast transformations or some spatial transformations, or like flip a brain left and right kind of things, and without changing the label. So this kind of encourages some sort of invariance for the model to learn. And alternatively, if you have, for example, a localization task, or like predicting a bounding box or a segmentation map, you want to transform both input and output the same way. So for example, flip left and right, you want to do this both for the input and the output, or some spatial transformations, sometimes some non-linear deformations, that kind of thing, that kind of clarify this, give us more information about the spatial dependence between these two. Now, crucially, here with data augmentation, what we're doing is that we are better defining this joint relationship, this joint distribution of inputs and outputs. Whereas in semi-supervision, as we just saw, we're only getting more information about this marginal distribution of inputs. So this means that data augmentation is maybe more flexible, it's more suitable for any kind of task. So whether it is causal or anti-causal, right? And there's actually an interesting emerging line of work that tries to learn augmentations from the unlabeled data. So just looking at a bunch of images, for example, it tries to learn or what kinds of transformations I can apply to the labeled data that look realistic. So maybe this can deliver on the promises of semi-supervision while building on this more reliable framework of data augmentation. Now let's move on to a second challenge of medical imaging machine learning for medical imaging, which is a data mismatch. And that is when your training data does not agree with or is not representative of the target population or target environment. And this can come about by two different mechanisms that I'm going to explain next. The first of them is dataset shift. And here we're defining dataset shift as the scenario wherein the training and the test data, target population, are different due to some exogenous factors. So maybe the cohorts are different, like demographics, or maybe the acquisition processes are different in these two environments. So here we're saying that the distribution of the inputs and outputs in the training environment is different from that in the test environment. And depending on the causal structure, as we'll see in the next slide, we can actually identify a number of different types, familiar phenomena that we intuitively know about, but this causal formalism lets us more systematically reason about them. Now, for example, in that brain tumor segmentation case that I mentioned earlier, for example, we can assume that the data was collected with a mostly adult cohort of patients and with a research scanner of, let's say, 3 Tesla high resolution, but then deployed for clinical use. So here we can expect a number of differences, right? So first of all, in image quality, because maybe what's used for routine scans will be a more conventional 1.5 Tesla MRI scanner, but also the differences in age. So if we're looking at a more general age range, that will first of all lead to changes in the sizes of the heads that we're going to encounter, the appearance of the brains, because that changes over age, and also prevalences of different types of cancer that we know are more common in younger or older patients, for example. So here, this is illustrated in the diagram here we have one node that indicates whether we are in the training environment or the test environment, and that has an effect on the prevalence of the disease, but also in the appearance of the image. Now, how we can think about this in a more structured way, remember that we are calling X the image, Y the target annotation. Now introduce this new variable Z that is the true anatomy of the subject that we're imaging, which is unobserved. So the only thing we know about Z is this potentially noisy proxy that is the image, right? And then we also have another variable that is the indicator. So for example, it can be test versus training domain, but it can also indicate hospital 1, hospital 2, hospital 3. Say if we have a multi-site study, right? So we can have variations across these different sites. And here we have two base structures. One of them is causal. So remember, causal is image causes annotation. So anatomy causes the appearance of the image that causes the annotation. So this is the same for all of these three. Now, this arrow here from the domain indicator into each of these nodes tell us about what parts of the generative process we assume is different or stable across these different environments. So if we assume that there are only differences in the annotation, in the anatomy, but the acquisition process, so this Z to X is the acquisition process, so we are collecting this this image, and then the annotation process. So if this arrow from D points to X, now we're seeing a change in the acquisition process, and here in the annotation process. And here at the bottom, I list a few examples of the differences that let us identify which parts of the process are stable across domains. And similarly, for the anti-causal case, we have annotation. So here would be, for example, the in that skin lesion example would be the true presence of cancer, causes some change in the anatomy, or causes the anatomy, right, and has some effect on whether there is a mole or not, for example, and then that gets imaged. So here, acquisition shift would mean, for example, if we are using a different kind of dermoscope, or in this case, a different kind of scanner, we know that even if we're using the same kind of contrast or protocol, say T1 weight that is more or less standardized, but the scanners can produce images that are fairly dissimilar, and even the intensity scales can be all over the place. For example, we can also posit that there could be differences in the manifestation of the condition that we're trying to predict. This is hopefully a rare case, but if it happens, then there's maybe not much hope of learning anything useful from your training data, right? So if you presume that you're trying to predict something that will look different in a target domain, maybe you need to rethink your application. So hopefully this gives an idea of how. So these are kind of base cases, right? So there can obviously be more arrows here. So D can point to multiple parts of this. So this is kind of help us look at the individual simpler cases, but there can be more complex cases in practice. Now, the second process that can also generate data mismatch is what I'm calling here sample selection. Now, here is the case where we know it's the same population that's going to be in the target environment, but for a reason, the training data that we have is biased with respect to that. So say we have some selection process, some inclusion or exclusion criteria, recruitment criteria, this kind of thing, that can basically mean that it's a subset of the population that we want to target with this model. Now, what's different here from dataset mismatch is that these are data-dependent changes. So either we have the full data and we kind of have some criterion based on the data, or, for example, just hospital admissions, right? The kind of classic pitfalls in statistics. So people who come into the hospital are already a biased subset of the full population, right? And this is different from the dataset shift, where we assume that those were external changes to the data generation process. Now, referring back to the skin lesion example, we don't collect biopsies from everyone, right? So we only have biopsies for images, for patients whose images looked suspicious in the first place. So this means that benign cases will be underrepresented in this data set because they didn't look suspicious in the first place, so the biopsy was never taken. And similarly, we can identify a number of different cases or situations where this sample selection can or maybe not have an effect on whether the data set is biased. And so obviously the simplest case is just some uniform random sampling, and that's great. That's the ideal case where we have no bias, basically, right? We have some ideal magical sample that is perfectly representative of the target population. Or we can have some image selection process where we, for example, look at the images and say, oh, we actually only want images where this organ looks like this, or we're doing kind of some sort of selection based on the whether there are lesions, the appearance of the lesions, this kind of thing. And this produces a bias that's similar to population shift, and we can apply the same kinds of solutions for this case. Alternatively, we can look purely at some quality control, right? So often it is the case that we'll download some data from a hospital, for example, and there will be images with artifacts, images that are super noisy, or images that like have some sort of aberration. Maybe the intensity scales are completely messed up, or there are some like objects or things in the image that we don't want to include because those could mess up our neural network. So that unfortunately introduces bias as well. So filtering for these images that have noise or maybe some bad contrast or artifacts will introduce some sort of bias that is similar to acquisition shift, which is, remember, if the acquisition process, like the scanning process in the target's domain, is assumed to be different. And again, we can apply the same sort of techniques to try to mitigate this bias. Of course, the selection can also be based on the annotation. So maybe we, as I mentioned, this can be just people who came into the hospital. That's a first kind of filter, right? Or we maybe filter by disease. If we have a data set that originally has many different conditions, we may want to do some quality control if we know that there are errors in the labels, for example. But also, when we're doing machine learning, there's sometimes some strategies that we use to try to preemptively compensate for some biases. So, for example, if you're trying to predict a class that is rare, so maybe some rare condition where you have 95% of your cases are healthy controls and you have some 5% of the target disease that you're trying to predict, it is often advised to do some sort of class balancing there. So either oversample the cases or undersample the controls. But this obviously introduces a bias because now you're messing up the prevalence of the condition, and then when you deploy it, then you will still in the target environment, maybe you'll still have those 5% and not whatever 50-50 that you try to balance. So there are techniques that can let you even things out and hopefully get better generalization. And finally, if you are selecting on both the images and the targets, this is called a collider bias, or more classically, selection bias, sometimes known as Bergson's paradox, where basically you are now creating a spurious correlation between the inputs and outputs. And for this, it generally requires some additional measurements. Maybe you need to control for some other variables. I'm not going to go into a lot of detail here, but there are some references in the paper that discuss specifically this kind of case. Now, to make this whole framework more useful for the community, we formulated this little checklist. So it's nothing too fancy. So basically just recommending to look at the whole story of the data set, try to see all of the steps that were, how did this data set come to be, and how did it arrive at my hands, right? So all of these selection criteria that happened along the way and so on. Try to infer the causal direction between the inputs and outputs, see if there are any differences between your training development data set and the target environment, and differences in image acquisition, which are maybe possibly the most well-studied problem in medical imaging, right? And finally, draw a diagram of this. And this helps you reflect on the implications. So, is this now independent of this? Is this true? is there actually an effect of this on that? Can we assume that there is a correlation between these two elements? And then this is an iterative process, obviously. And also we kind of formulated this sort of scaffold or template diagram that hopefully represents most kind of typical analysis scenarios, and that can easily be adapted to specific applications by just kind of adding or removing elements. Sometimes you may want to assume, for example, here, that the annotator may often be aware of the patient record. So you may need to additionally assume that the patient characteristics have an effect on the output label, or that the diagnosis affected the annotation. So this gives a kind of a basic structure that people can build on. Now, just before concluding, I'd like to do a quick detour to tease some of our more recent work on another causality topic, which is on counterfactual inference. So this is the sort of question of what if A were B instead? So kind of a hypothetical change, but to a specific individual. So say we collected an image, we have some demographic information, some clinical measurements, and we want to ask, oh, what if this person were not a smoker? Or what would, let's say a brain, for example, what would a brain of someone who has all of the same characteristics, but is 5 years older? Or like, what would the brain of this person look 5 years in the future, or 10 years, or, you know, these kind of hypothetical interventions. That's how we understand counterfactuals. And here we basically assume there's some structural causal model that generates this data. And in this paper, we propose to use deep learning to model these relationships. And we do a proof of concept study on brain MRI scans from the UK Biobank dataset. And we include variables age, sex, brain volume, and ventricle volume. And we assume this graph, we notice probably not fully accurate, but it was just kind of, it is somewhat informed by medical literature, and it's visually, these assumptions make sense. And here just some of the results that we managed to obtain, that, you know, we have some original brain here, original characteristics of these two subjects, and we can perform all of these interventions and see how the brain would look like with these different characteristics. And what really surprised us when we actually derived these results was that by actually following causality literature on counterfactual inference, we actually managed to, for example, preserve some measure of identity here. So, you know, all of these cortical folds are preserved after performing these interventions, which is something that other methods in the literature were not able to do. So this is something that we're really excited about. If someone's interested, we also have a demo that I could show you on like performing these little changes, the volumes and the sex and the age. It's actually really cool. So now to just wrap up, we had a look at causal reasoning, how we can apply that to medical imaging. It gives us a new say, way to think about some of the challenges we face in a more systematic way. It helps us identify different bias pathways, so things that can introduce some undesired artifacts into our data set and then into our models that can hurt the generalizability or external validity of these models. It can, in some cases, inform our choice of learning strategies. So as we saw, for example, between semisupervision and data augmentation, let's just think about some of these trade-offs. In the end, having, like, if we collect a data set and then we present a diagram like this, we make these assumptions immediately clear to other researchers who can immediately look at it, recognize our assumptions, and obviously also criticize. I think this is a really important point that maybe we're not always right, and in some cases things may be ambiguous. So we may not be able to accurately tell whether image causes the target annotation or the other way around. But if we write that down and we build our analysis based on that, other researchers can look at it and maybe criticize it and say, wait, I don't agree with this. And then we can have this discussion on a level where have a productive conversation about the assumptions without them being implicit, which is the usual case. And as briefly illustrated with that counterfactual work, this also opens the door to new potential new applications, leveraging the whole power of causality theory. So we could do causal inference, so try to estimate effects of different variables on the appearance of the image, or vice versa. Maybe causal discovery. So can we just, given some raw data, can we try to detect if there are some causal relationships between all these variables? So this is stuff that we're really looking forward to investigating more in the future. Now, just one final shameless plug. If anyone's attending MICAI next month and is interested in causality, we are organizing a tutorial, and it would be great to see you there. And that's it. Thanks for your attention.
Thank you so much, Daniel, for that wonderful presentation. I think it's really nice for us to take a step back and think about some of these considerations that sometimes can be taken for granted, like what are the sources of biases in my data? How can I actually correct for them? And I really like the perspective that you included on the framework that researchers can draw for their own experiments. Because in medical imaging, so many times the answers for most questions is it depends.
Yes.
And I feel like using that framework, it may help us make studies a little bit more repeatable, a little bit more reproducible. And I feel like there should just be a larger push into that direction in the first place. So thank you again for sharing that presentation.
It's largely about the communication and making these things transparent.